గుడ్ ఈవినింగ్ అండి. అతనితో మాట్లాడానంటే మెయిల్ కూడా పెట్టాను. సారీ, మెయిల్ రేపు పెడతానండి. వీళ్ళందరికీ పెట్టాను, సిఎన్ రెడ్డికి. అదే రేపు మార్నింగ్ పెడతానండి. నేను ఇది సిఎన్ రెడ్డికి పంపించాను, ఆయన ఓకేనా కానీ రేపు పెట్టేస్తాను. మెయిల్ అండి, మాదేవ్ అనుకో. అతనితో మాట్లాడాను. అవునండి, ఏం లేదండి. అవునండి, లేదండి. ఫరాన్ షేక్ వాళ్ళ ఫాదర్ చనిపోయాడు, అతని బదులుగా డాక్టర్ దినేష్ చీర్లా మాట్లాడుతున్నాడు. ఏమో సార్, మనకు రీజన్ తెలియదు. మన దినేష్ ఫోన్ చేసి నిన్న రాత్రి చనిపోయాడు, అందుకే అతను రావట్లేదు, అతని ప్లేస్లో నేను ప్రజెంట్ చేస్తున్నాను అన్నాడు. సో ఆయన కూడా పంపించాడండి, మీకు సివి పంపించాను. మీరు ఎట్లా కోహోస్ట్ కానీ మీరు చేసుకోవచ్చు, కోహోస్ట్ కాబట్టి మీరు చేసుకోవచ్చు, లేదా చదవండి. చదివేశాను ఏం కదా. తర్వాత అండి, డాక్టర్ ధిరేన్ 8 వరకు అతను ఇంకో దాంట్లో ఇన్వాల్వ్ అయినట్టు రాశాడు. లింక్ పంపించాను, మళ్ళీ పంపించండి అయితే ఒకసారి. నేను పంపిస్తాను. ఓకే. ఇంకొక రిక్వెస్ట్ వచ్చింది. ఎవరు సతీష్ గంటే రిక్వెస్ట్ చేసేటంటే, ఒక అడోలిసెంట్ రీనల్ ట్రాన్స్ప్లాంటేషన్ అయింది, పార్షియల్ రిజెక్షన్ ఉంది, COVID-19తో సఫర్ అవుతున్నాడు, క్రిటికల్గా ఉన్నాడు. తర్వాత ఇంకేదో ఒక న్యూ బార్న్ కూడా ప్రాబ్లం ఉంది, నాకు ఒక్కసారి ఛాన్స్ ఇస్తే నేను జస్ట్ డాక్టర్ ధిరేన్ గుప్తా తోటి క్లారిఫై చేసుకుంటా 1 or 2 డౌట్స్. అది ప్రజెంటేషన్స్ అయిపోయినాక ఉంటుంది, నేను సంజయ్ గారికి చెప్తానంటే, అదే సంజయ్ గారికి చెప్పి నాకు ఛాన్స్ చేయండి ఫస్ట్ అని అన్నట్టుగా. అతను లైవ్లో వచ్చి 1-2 అడిగి అతను క్లారిఫై చేసుకుంటా అంటున్నాడు. అవును, అదే, అవును, 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 అవును. అట్లా అంటే జనరల్లీ మనం వెబినార్స్ ఎట్లా చేస్తున్నామంటే 2 ప్రెజెంటేషన్స్ అయిపోయాక చివరికి అడుగుతున్నాము. ఒకవేళ ధిరేన్ ఏమన్నా ఐఎమ్ టైర్డ్, ఐ వాంట్ గో బ్యాక్ ఆర్ ఐ కెనాట్ స్టే అంటే, ధిరేన్ అయిపోగానే మీరు స్టార్ట్ చేయండి, మీరు తనతో మాట్లాడి. అదర్వైజ్ అవునండి, అంతే. ఓకే, ఓకే, ఓకే. నేను ఎందుకంటే అవును, ఈరోజు మధ్యాహ్నమే ప్రజెంట్ చేసేదండి, సేమ్ టాపిక్. థ్యాంక్స్ అండి. ఓకే, చేసి కరెక్ట్ అంటే అదే అంటే చాలా సంవత్సరాలు చేసినదండి, ఒక స్టేజ్లో అనిపిస్తుంది అట్లాగే. సరే అండి, ఓకే అండి, ఓకే అండి, నో ప్రాబ్లం. ఓకే, నేను ఆల్రెడీ లాగిన్ అయి ఉన్నానండి, మీరు ఎనీ టైం యూ కెన్ జాయిన్. సరే, ఓకే, ఓకే, ఓకే. అవుతున్నాను. నేను ఈ మధ్య ట్రయల్ అండ్ ఎర్రర్లో యూట్యూబ్ రికార్డ్ చేద్దామని నేను ట్రై చేశాను, వచ్చేసింది. మీరు కూడా వచ్చేసేయండి. ఓకే, షూర్ షూర్ షూర్. ఓకే ఓకే, షూర్ షూర్. నాకు నన్ను ట్రైన్ చేయాలి మీరు. ఇప్పుడు యూట్యూబ్ రికార్డింగ్ అవుతుంది. దీన్ని మళ్ళీ నేను జూమ్లోకి రావాలంటే ఎట్లా? జూమ్ లాగిన్ అయ్యాను, ఆ తర్వాత యూట్యూబ్ రికార్డింగ్ కూడా స్టార్ట్ చేశాను. అవుతుంది, యూట్యూబ్దే అవుతుంది. ఇప్పుడు దీన్ని మళ్ళీ హోస్ట్ కాదు, మాకు ట్రైన్ చేయండి ఇవాళ. చేస్తాను మిమ్మల్ని. నాకు హలో తీసుకుంటున్నాను. హలో తీసుకుంటున్నాను. Hello, Sri Krishna.
Sir, good evening.
Yeah, good evening, Sri Krishna.
First, మీరు ఇద్దరు స్పీకర్స్ మోడరేటర్ ఫస్ట్ తీసేసుకోండి, స్క్రీన్ షేరింగ్ అవన్నీ చూసుకోవాలి వాళ్ళు.
ఓకే, ఇప్పుడు ఇది ఓకేనా? యూట్యూబ్ రికార్డింగ్ అవుతుంది, ఓకేనా?
లైవ్ ఆన్ యూట్యూబ్ బానే ఉంది. దీని లింక్ కాపీ స్ట్రీమింగ్ లింక్ అని పెట్టాను. మీకు ఇప్పుడు గ్రూప్ లో పెట్టేస్తాను, అయిపోయింది. మీరు ఆల్రెడీ సెట్ చేస్తారు, ఇంకేం చేయనక్కర్లే మనం.
ఓకే ఓకే, అడ్మిట్ చేస్తున్నాను.
స్పీకర్స్ ని అడ్మిట్ చేసేయండి. ఐడియల్ గా ఏంటంటే మనం సెషన్ స్టార్ట్ అయిన తర్వాత స్టార్ట్ చేయండి యూట్యూబ్ లైవ్.
ఆల్రెడీ లైవ్ నడుస్తున్నాను ఎప్పుడు?
అదే అంటే ఇవన్నీ కూడా లైవ్ లో వస్తాయి.
ఓకే, పర్లేదు. Now Dr. Dinesh is inside. Dr. Sanjay is inside. Hello sir, good evening sir.
నన్ను ఒకసారి హోస్ట్ చేస్తే వీళ్ళు కో-హోస్ట్ చేయాలి సార్.
Sure sir.
సంజయ్ సార్, గుడ్ ఈవినింగ్.
Hello, Chabu.
భాస్కర్ సార్, ఐ మేడ్ యు కో-హోస్ట్.
Doctor,
మీరు ఇప్పుడు బయట ఎవరైతే అడ్మిట్ అయ్యి ఉన్నారో వాళ్ళని యూ కెన్ అడ్మిట్ దెమ్. ఐఎమ్ మేకింగ్ ద అదర్స్ ఆల్సో కో-హోస్ట్, దట్ వే దే కెన్ షేర్ దేర్ స్క్రీన్ as well.
Dr. C.N. Reddy, Dr. Dinesh, Dr. Sanjay.
మీరు అందరిని అడ్మిట్ చేస్తారా?
చెప్పారు అడ్మిట్ చేయండి.
We don't have to make everyone as yet.
Yeah, anyway, some of them are coming.
All right.
Good evening.
Hello, good evening.
C.N. Reddy sir, good evening.
Good evening. చాలా రోజుల తర్వాత కృష్ణ.
Sir. Request the speakers to please identify yourself and then share the screen. Dr. Dinesh, you need to test your audio and your screen sharing. Bhaskar sir, we'll just wait. After 8 o'clock, we'll start admission of the remaining people.
Yeah. Dr. Dinesh is inside now. Good evening, Dr. Dinesh.
Right. So, could you just go to full screen? Yeah, just please proceed. Are there any videos in the presentation? Great. I think this is fine. I'm just stopping your screen share.
Dr. Dhiren has joined just now. RSV.
Okay.
Yeah. Name, sir? It's on the name of Dr. Dhiren. Yeah, Dhiren Gupta.
Yeah, correct, Dr. Dhiren Gupta.
Yeah. I just make him the co-host. So
Dr. Dhiren.
Yeah, good evening.
Good evening, sir. Good evening.
Dr. Dhiren, please check if you can share screen and also your voice. Dr. Dinesh, we didn't hear from you.
Good evening, everyone. Good evening.
Good evening. Good evening.
Good evening. Good evening, everyone.
Good evening.
Oh yes, we can.
It was on mute. Yeah,
we can see you. We can hear you. Your screen was visible as well. You're all set. I think we start with Dr. Dhiren's talk first, right?
Yeah, that's it.
Yeah, Bhaskar will introduce.
Yes, sir. In terms of the order, just wanted to know. Dr. Dhiren, you need to share your screen.
Just
and
2
also
minutes.
test the audio.
Give me 2 minutes.
Yes, sir. Take your time. Yeah. Bhaskar sir, can you just check if the YouTube link is working? మీరు పక్కన ఒకసారి చెక్ చేయండి.
It's okay.
Sudhakar చెప్పండి సుధాకర్. I am
Sir, good evening.
hosting.
Right. Dr. Dhiren, do you have any videos in your presentation?
Yeah, they are covered. Means the face is adequately covered and genitals are also covered. No problem.
Okay. Great, sir. Great. Because
Yeah.
if there's anything, YouTube can stop it
Yeah, I
anyways.
know.
We've had that experience.
I know that.
Right, sir. And the second thing, if there's a video, if there's an audio along with it, then you need to have checked share computer audio while you share the screen. Only then the audio will be shared. So
Okay,
if you
yeah,
want to have.
the audio is not very important. Anyway, it is shared otherwise.
Okay, great, sir.
Yeah, it's shared. Speaker, headphone, everything is shared.
Thank you, sir. We're all set. I'm just stopping your sharing and we have a minute to go and then we can start.
Dhiren sir, good evening. Dr. Sheikh here.
Oh, good evening. Good evening. So how are you?
All well, sir. Your pleasure. It's always pleasure to listen to you and Farhan also.
Farhan, unfortunately, couldn't come, but Dr.Dinesh is there.
Okay, sir. Okay, sir. No problem.
Whenever you, instruct me, I'll share my screen. Fine?
No problem, doctor. No problem.
It's 8 p.m. sharp. Dr. Bhaskar, we're good to start.
Yeah, Dr. Bhaskar, you can do.
Right, sir. So at the outset, welcome everyone to today's IAPTCB webinar. You'll all be muted by default setting, and over to Dr. C.N. Reddy, President IAPTCB, for his inaugural remarks. Dr. C.N. Reddy, please unmute yourself. The co-hosts can unmute themselves.
The CN Reddy sir, unmute చేయండి sir.
Hello, respected seniors, dear colleagues and postgraduates. Good evening to all of you. On behalf of IAPTCB, I welcome you all to this webinar on COVID-19, need of the day. We have a wonderful speakers today. Dr.Dhiren Gupta ji from Sir Gangaram Hospital is the senior pediatric intensivist, having this pandemic experience, lot of experience, and he is going to share all his experience today, and he will enlighten us regarding the COVID-19 prevention, management, concepts, and controversies. Thank you, sir, for accepting our invitation. I welcome you, sir, to today's Twin Cities branch of Indian Academy of Pediatrics. And second topic is by, actually it was Farhan Sheikh, but unfortunately he could not attend. Dr. Dinesh is presenting the second topic. Thank you very much for accepting our invitation. Thank you, Dr. Dinesh, for coming and joining us tonight. And Dr. Dinesh is a senior most and eminent neonatologist and intensivist of Twin Cities. He is a consultant and director of Rainbow Children's Hospital. And today's moderators, we all know Dr. Sanjay Srirampur. He is a well-known academician and well-known speaker, national speaker, and committed IAPN. He has given his services at branch level, state level, and also national level. Thank you, Dr. Sanjay, for accepting our invitation and coming and moderating this session. Now over to Dr. Bhaskar for the introduction of speakers and other proceedings. Over to Dr. Bhaskar. Dr. Bhaskar.
Yeah, am I audible?
Yes, yes.
Yeah, thank you, President Dr. C.N. Reddy. Good evening all and welcome to 43rd IAP Twin Cities branch webinar. We had started on 1st of May and today is the 43rd webinar. So today is a special day because the two speakers who are going to address us have first-hand experience on COVID-19 patients. And my special thanks to Dr. Dhiren Gupta for accepting our request instantaneously. And my special thanks to Dr. Dinesh Kumar Chirla for coming at our rescue in place of Dr. Farhan Sheikh. Due to some unavoidable reasons, he is unable to present his presentation. And I should appreciate Dr. Sanjay Srirampur because he is the person who had recommended these speakers' names. He is the person who had encouraged me to take up this topic. And despite his busy schedule, just 1 hour ago, he was presenting on the same topic with IAP Andhra Pradesh, probably just 1 hour ago. Despite that, he is looking fresh and came here. It shows his concern about the Indian Academy of Pediatrics Twin Cities branch. Thank you, sir. And my special thanks to the participants. Already it has reached 87. I'm sure it crosses 100. So it shows the interest of our participants on this topic. With these few words, now I request our moderator, Dr. Sanjay Srirampur, to take over and conduct the proceedings. Over to Dr. Sanjay Srirampur.
President Dr. Am I audible, sir?
Yes, yes, sir.
President Dr. C.N. Reddy, Secretary Dr. Bhaskar, Dr. Dhiren Gupta. Thank you, Dhiren, for accepting our invitation. I know you are busy and I know you are so much a specialist in treatment of COVID that when the Twin Cities said that they wanted a seminar or a webinar on COVID, I said there's none other than Dhiren who can speak on this topic. Thank you very much for accepting. I know you are a very busy man. Ladies and gentlemen, we are going through unprecedented times. Probably we or the last two generations have never faced this sort of a situation. There is fear everywhere. Fear of loss of income, fear of death, fear of illness, fear of hospitals, fear of doctors. Unfortunately, we are losing some of our colleagues. We lost Dr. Kapse today. The disease has altered our everyday life. We have almost lost all social interactions except the virtual world. And the scenario of COVID is rapidly changing. Way back in January, when it started, we thought it was an acute respiratory infection. Now we know that it is probably a vascular disease. And as we go forwards, what is there to unravel? Probably we will find out. We thought it was an acute disease. We are coming to know that probably it has long-term consequences. We thought that N95 was the only source of prevention. Now we say that some sort of a mask is more than enough. We thought that antivirals will help. And in fact, we never knew about those VIR ending drugs. Actually, we used to skip those when we used to read. And all those mabs, tolizumab, salizumab. We always used to skip those when we used to read Nelson's. So the topic is so big and the time is so short. In fact, I was just thinking how our knowledge on COVID is evolving. It is like the 6 blind men looking at the elephant. Now, one catches the trunk and says that it looks like the tree. The other catches the teeth and he says that it is like the spear. And the other catches the tail and thinks it like a rope. So it's just like the 6 blind men. And everybody is right in his own context that the description is perfect. But what is the real story behind? We need to understand. And as we go forwards, we are understanding. And believe me, probably the world and our approach to illnesses will change after COVID subsides. We have with us 2 very eminent speakers, Dr. Dhiren Gupta from Gangaram Hospital and Dr. Dinesh, who has come in place of Farhan, and he will do a very good job. Dinesh, we all of us know. Dr. Dhiren Gupta, to give you a formal introduction, is a consultant pediatric intensivist, Sri Gangaram Hospital. He received the Visishta Chikitsa Ratna Award for contribution in the field of pediatric intensive care. He was the chairperson and founder of the acute care for practicing pediatricians module by the IAP. He was the coordinator for IAP GEM course. He was the guest executive editor of Indian Pediatric 2016-2017. He did his graduation from Gwalior as well as post-graduation from Gwalior, and he's in the pediatric intensive care department of Gangaram Hospital since 2001 onwards. Started as a resident, senior resident, and now he's the consultant pediatric intensivist of Gangaram Hospital. It is our honor, sir, that you have accepted our invitation and chose to speak today on Sunday evening. I know how Sundays are. You must be busy all the days. We are stealing your time. It's all yours, sir. Your attention to Dr. Dhiren Gupta. You can start sharing your screen, sir.
Thank you, Dr. Sanjay. And in fact, you have summarized the whole presentation. You have helped me a lot. And imagine even after 7 months of this pandemic, we are learning. We don't know where it will end. In this presentation, I thought of that what paradigm has shifted over the months, you can say. Normally for the disease, we say over the years. For this disease, we say over the weekends. Over the weekend, things changes very fast, including thought processes, including management, including preventive modalities, and lot. So this virus has baffled everybody. And now we are looking at the long-term consequences, problems which patients are facing, and they are really devastating problems everybody is facing. It's not an easy to live in post-corona time also. It is stuck, I think it's not moving. Yeah. So today I kept my aim very small because it's just 25-30 minutes. I'm going to talk about paradigm shift in the spread and preventive measures which can help us regarding management and what is new in pediatric COVID. We were almost jobless for 2 months when COVID struck the, you can say, this part of continent. Pediatrician didn't have work, lost the say in big hospitals because they didn't have work. So adult patients acquired most of the pediatric places. Somehow past 1 month, we are viewing this, you can say, multi-inflammatory organ involvement disease. We call it MISI. I'll be talking a little bit about. Let's start with what we used to think 4 months back and presently what we are thinking. I remember when I was visiting a COVID hospital for an inspection where pediatric patient likely to be admitted. Looking at the hospital, it looks like that COVID will jump from the 3rd floor where patients are there and will enter me. It was scary looking at the hospital. Presently, I have worked with the adult in their intensive care, in their emergency ward, in their wards. I found that if you look at the coronary, this COVID hospital from outside. That is more scary, but if you work there, it's very cool. Same thing we found in the research that is applicable to our institution and many of the institutions in India, as well as this paper from, you can say, a Tongai hospital, where what they found in frontline worker of COVID ward, actually just 0.55% of the people got infection with COVID, SARS-CoV-2. Whereas the low risk areas, which we used to call like a non-COVID areas or non-COVID hospital part, there the infection rate was pretty high as compared to COVID areas. That was around 1.5. Same experience we have. Patient 300 healthcare employee who got infection, and you'll be surprised that in COVID ward, just 3 to 4 patients, so 4 employees got infected as compared to non-COVID. So it was like a 98% versus 2%. Presently, I'm pretty confident to say COVID hospitals are much safer than so-called non-COVID. So there is nothing like a non-COVID presently, but if somebody is not labeled as a COVID, there are no probable patients of the COVID inside. I'm talking about private setups. They are maybe unsafer than the COVID one. If you label any hospital COVID, everybody is, as their toes to take up the gears, to don the proper gears to prevent it. If you are able to prevent yourself by donning proper gear, actually you are preventing other people from the COVID. So if you wear any mask, it is more preventable, you can say a more preventable PPE for other people. To acquire infection, it may be effective as like 95%, but it will be 99% effective to spread prevent the spread the infection, to prevent the outgoing infection. Now comes the mode of spread. It took WHO to define the mode of spread. Actually, WHO fooled everybody. Whether with the China or whether the lack of knowledge they want to distribute, whatsoever the reason was. They didn't mention about the emphasis of the mask to start with. If they would have done there, probably we could have prevented. So when we started, it started with like fomites, touch, aerosol and droplet. So aerosol came last and fomite, touch and droplet as the first former, you can say, reasons for the spread, mode of spread. That's why you must have noticed that our governments were busy in showering and wasting their disinfectants in the open grounds. That was a waste of money. That is not recommended. We also emphasize most on the touch, how to prevent from the touch, and we'll end up in paying the huge money for the fancy things which we imported from the China other than coronavirus. Now, after say also almost 3-4 months, what we can say, fomites and touch, less likely this infection spreads as compared to the aerosol and the droplet. What is the evidence? There's a lot of evidence on based of experimental studies, as well as actual super spreaders. Let's take an example of this super spreader. This super spreading event happened in the south of the Korea in this building. You can see this building on the right side. What happened? An infected employee who was mildly symptomatic came to work on the 11th floor. 11th floor must be here. This is around 15th floor building. And this is an area. All these blue people actually got infection. It is something like a 43% of the people out of 216 employees out of this floor got infection, of this part of the floor. On the other part of the same floor, only 6 out of say around 500 people got infection. So what they could conclude from this infection, probably droplets or aerosol likely, but fomites unlikely. Why? Because all the building which I showed you had common lift and doors, and none of the people of the whole building got infected. Okay. So what we did over past 3 months, we wasted a lot of resources for disinfecting our, you can say, the various doors and the floors, and less emphasis towards the masking. So one thing is very clear: if you share the same air without good ventilation, increases the chances of exposure to this infection. Let's take another super spreader. This happened in Guangzhou, that is south of the China, in the one of the restaurant. There are 3 tables: table number A, table number B, and table number C. Okay, this pink man, this one, A1, came from Wuhan and had dinner with 9 friends on the table A. Okay, you can view this. This red people got infection, and the skin colored people didn't got the infection. Now look at the restaurant. This is around 6 meters. From the left side, there's an air conditioned, and here is the vent. Okay, so flow was from the left to right. What happened? Maximal person who got infection is from the table A. On the table B, almost 75% people got infection, and as compared to table C, 2 out of 6 people got infection. 2 out of 7 people got infection from the table C. So what you could conclude, and people concluded in very wrong way. They started blaming the air condition. It is not the air condition which should be blamed. It should be the improper flow of the air and inadequate exit ventilation that has to be blamed. So if I summarize this super spreader, table C got the infection, that we understand, means it was means away from the flow also. So very likely this is due to the aerosol or the turbulent flow. So that's why the new recommendations are there. If your air condition is like this, the reef of the flow should be above, not should be directing the people. Okay. And secondly, your ventilation, that is your exhaust fan, should be strong enough to vent the whole of the air which is present inside the cabin, or in this place it's a restaurant. So exiting air volume should be more than the airflow inside the you can say, containment area. So again, direction of flow is very important when we talk about air condition. Just stopping the HVAC, that is heating, ventilation, air conditioning system, is actually injurious, which is happening in most of the malls, most of the places. They switch off the AC. They feel that you increase the temperature, you roast the people, but this virus is not getting roasted. And the same thing is happened in the hospitals. In the government hospital, they switch off the air condition. And what happened? Wearing PPE, you increase your thermal distress. You cannot examine. So nobody came to examine this patient when they were in distress, because no one can work in a 40-degree temperature. So that is a major fault. People read this, you can say, super spreading event in a wrong way. What is the other evidence of airborne infection? This was a study which was done in Nebraska, that is an ICU, recently published, though the non-peer-reviewed part published around 2 months back. What they did, they sampled the air from the ICUs and the general ward, and they found that 63% of the air samples in the 11 patient room, they found this SARS-CoV-2. As well as outside the patient room, they found that almost 66% air samples were having this infection. Also, they found that personal items like exercise equipment, medical equipment like spirometer, pulse oximeter, nasal cannula, personal computers, iPad, reading glasses were having some virus on that, you can say, fomites. Cellular phones were mostly contaminated, and also they found that remote control for which normally spouse fights, and they found that they were also infected. And the most important part was the toilets. Toilets were contaminated to the tune of 81%. You must have heard lot of studies where they were mentioning that this virus can stay on the plastic for 2 days, 3 days. Those studies were actually experimental, and the amount of virus was huge. That is not normally in the, in nature, it doesn't happen. That's why we had an idea, we had, you can say, misconception that fomites is very important part of spread. It is important, but it is less important as an airborne transmission. So what is the implication if I call it airborne transmission? If I call it predominantly, you can say droplet transmission, what we can define this infection as a droplet with opportunities airborne. So a lot of opportunities this infection is getting to become an airborne. So you can say paradigm shift from no mask, which WHO said around 4 months back, to universal masking. So not only universal masking, when we talk about outgoing prevention, suppose I am wearing mask, and what way I can able to prevent the outgoing infection if I am a carrier? It is tuned to 99%, whatever mask I wear. It should not have an expiratory, you can say, valve. So preventing other people by masking myself is in fact the most important thing. Any mask you can use, but as a healthcare worker, the paradigm has shifted from your simple mask to N95 mask. So there's a shift of the mask use, that if you are a diseased, you can wear any mask. If you are carrier, you can wear any mask without expiratory valve. But if you want to prevent yourself as a healthcare worker, it has to be N95 mask, whether you are working in COVID ward or non-COVID ward. As I told you, there is nothing like non-COVID. Now we come to the change in the environment. What is the implication of this environmental change? When we talk about now, more prominent is not only droplet, but opportunistic airborne also. As I am again emphasizing, these are ISHRA guideline, Indian Society of Heating, Refrigerating and Air Conditioning. We call it ISHRA. These are the guidelines published by Government of India. They say that HVAC should not be shut down at any cost. You have to modify your HVAC system. You have to make thermal convenient atmosphere. Otherwise, there will be too much thermal distress or stress that can lead to a lot of infection propagation in healthcare worker. That is the problem. Imagine at 40 degree or 38 degree, you cannot tolerate even simple N95 mask. So you will try to put in your finger inside, and you will not only contaminate yourself, but you can become an infection spreader. What is this environmental modification? These are the two diagrams. This is not for like to find out the 10 mistakes type, but this we call it SMS. SMS is an acronym which Dr. Bakul Parikh has given. Understand that what happens when infection spreads. There are three forms. One is droplet. When we call it droplet, means bigger droplet, that is more than 5 to 10 micron. Second is small droplet. We call it aerosol. Okay, or we can call it micro droplets. This droplet, when exit, can end up as a fomite, which sits on the area around. Second, this aerosol can infect the people inside, or if the other person is in the striking distance, then this fomite can directly settle on the person who is around. It may be 2 meters, 3 meters, 6 meters. Now we say that for an infected patient who are actually infected, it may be 3 to 4 meters. But if it is, you can just asymptomatic carrier who is not coughing or who is not sneezing, 2 meters. So it means that if we are profiling our infectious material in the atmosphere, that is more harmful, though asymptomatic carriers are again harmful. But we are focusing on environmental modification. Now, what happens to these droplets? This droplet will settle, so we need to clear up the fomites. We know that sanitation is important, disinfection is important. But what happens to this aerosol? If your windows are closed and there is no exhaust fan, they will stay in atmosphere maybe 1 or 2 or 3 hours. But look at the B number. We have done everything right on the B side. What on the B side we did? the reef of the air condition, we pushed up. So there is no direct turbulence flow as it was happening on the A1. Secondly, the most important thing which you can do in your clinic is put up an exhaust fan that is near the dirty part. If patient is sitting here, direction of flow should be from clean to dirty. So whatsoever is accumulating in this room will get exit from this means exhaust fan. Okay, so you need to know the strength of this exhaust fan as per the room size. So what will happen? By putting up an exhaust fan, you have created a sort of negative isolation and you have cleared up all aerosolization. And the most important thing is the masking. Social distancing, that is S, then masking. Masking is you ask the patient or the spreader to wear that mask, to don the mask. Other than the nurses, also we should include that eye protection in form of eyeglasses. So what we have done social distancing, means nobody should be allowed to enter the room other than the nurse and the healthcare worker. You have actually masked everything. Okay, and sanitation, we have talked about fomites clearance. So this is the most important slide, I would say, out of this presentation. Now we focus on the clinic, especially that was a hospital room. And if doctor is sitting on one corner, air condition should be near to the doctor. The influx of the air should be near the doctor and it should be towards the patient. So clean and dirty. So it should be from clean to dirty. If somebody has got a toilet, adjoining toilet, he should switch on the exhaust fan. Ideally, your exhaust fan should be around 1 feet above the ground near the patient end. So these are the ideal recommendation for the clinic. And as I told you, that reef of the air should be above rather than from the below. People come with an idea, okay, can we put up a fan behind the doctor so that everything goes in front? No, these things will produce turbulence and it's not good to have these type of recommendations. Now, these are the photograph of echo room where it's a closed room. There was no exit. So what the hospital does, it included lot of, you can say, pipes, you can say, inside and put an exhaust fan. So what this exhaust fan is doing, it is taking up the air and is getting this air vented out of the hospital. And very important, where it should be exhausted ultimately. Exhaustion should be at least 3 meters above the roof at the point of discharge. So that is very important. It should not be like here. Otherwise, you are going to contaminate people who are around that building. So that is very important. So there are guidelines, ISHRA guideline. You can go through. It gives you guideline about your clinic. It gives you guideline about UV rays. It gives you guideline about operation theater. I didn't include it, but gave you a hint that these are available and you can go through. In fact, IAP is also coming up with a document by the name of social distancing that includes all the practical recommendations which we can include in our clinics to prevent the spread of infection other than the PPE, that is the masking. So masking is very important. Social distancing is most important, and environmental cleaning, that is by exhausting the air out, is probably the most important secondary to mask. Now we come to other part. Why this virus is silent? This is something like a world war is happening, but silently. Okay. So China didn't spend a penny, but it led to the world war. So same thing, the virus is silent spreader. Like in a carrier state, you don't know that the carrier state is not having actual symptoms to start with. Many of the patients are actually human beings. They've never turned out to be patient means any human having symptoms, but they were carrier. So it is sort of a virus which is silently inside the body, and that is spreading, that is being spread to other people. Second is why there is silent hypoxia. We call it happy hypoxia. Let's start with transmission of this infectious material, how it happens. Imagine this is a primary case, A, and this is your secondary case, which has got infection from the A. When infection enters the primary case, say day 1. Around day 3, it become contagion. It started spreading the infection. Okay. And the peak of the infection, you can say a contagion, is just before the symptom onset. Okay. So peak happens almost 6 hours before the patient develops symptoms. So it is a silent carrier, or you can say pre-symptomatic carrier. At that time, it gives infection to other person, which become a secondary case. Look at another example of influenza, another, you can say, virus. It happens when patient develops symptom. The peak of the, you can say, contagion coincide when patient develops cold and cough. So we come to know, okay, this patient is having cold and cough, so stay away. Fine. So it's easy to be away from a person who is, you can say, who is shouting. Like Arnav Goswami, everybody knows he shouts, and you come to know even 2 rooms ahead that which channel is there. Okay. But you won't come to know about NDT, which is a silent killer, means it's very silent. You won't come to know, okay, Ravish is speaking unless you open up and try to listen. So same way happens in the SARS 2003, that is SARS-CoV-1. As you can imagine, viral spreading peaked with the disease process. So when the disease was at its peak, it leads to secondary infection as compared to in the present one, that is the younger brother of SARS-CoV-1. Now, why it is happening? People are speculating. People did a lot of studies, and what they found that this virus attaches to the goblet cells of the nose and the throat. Okay, these are the goblet cells. And it proliferates 2 to 3 times faster than SARS-CoV-1. So it spreads, its growth is 3 times faster than its elder brother. But the immune reaction, it bypasses. So there is no symptomatology because it bypasses interferon 1 and 3 mechanism. So there are no major symptom produced at that level, but patient becomes spreader. That we call it pre-symptomatic or asymptomatic spreader, because it bypasses lot of immune reaction. That's why a lot of speculation, which were actually proved by a lot of studies, that if you use hypotonic saline, it hydrates the aqueous layer. It hydrates the aqueous layer of and increases the calcium efflux, and thus way it improves the mucociliary clearance. And by use of povidone iodine, you can actually kill the virus. So that's why it is being used as a prophylactic measure at like hypotonic saline and povidone iodine. Hypotonic saline is easy to instill in the nose. It comes with the, less than 5% is recommended. And povidone iodine gargles you can use for the throat. So this, once you acquire, you can use after acquiring, or you can use it prophylactically. Now we come to very interesting part. What is the silent hypoxemia? Actually, happy hypoxemia is coined by the journalist. It is actually a silent hypoxemia. What is the silent hypoxemia? I am having saturation of 88, but I'm not having dyspnea. So that is actually patient having low oxygen level, but not having, you can say, features of dyspnea, not experiencing the features of dyspnea. That's why we say that I don't have money in the bank, still I am happy. So this happens not very uncommon in India. What is happening? I could gather in one of the study which was published in Respiratory Physiology and Neurobiology. It tried to conclude by including almost 200 studies. What they were able to conclude that there is an AC2 receptor at the COVID bodies, at the carotid bodies. There is an AC2 receptor. So this receptor is, we all know that COVID-2 get into this through the AC2 receptor can enter the cells. So what is happening? Whenever patient is feeling hypoxemia because of lot of factors like reduced capacity of oxygen transport in the blood by affecting the lungs, but since it affects the carotid body, there is an insufficient central command to compensate the increase in respiratory rate. So whenever I feel hypoxemic, there should be increase in respiratory rate and increase in tidal volume. I should feel breathless. So that capacity of human being is impaired because the body which is responsible, that is carotid body, get affected by ACE2. Whether it is by directly or cytokine, nobody knows. So it says that it impairs the oxygen sensing mechanism of carotid body. That also coincide with the reduced capacity of the oxygen transport in the blood. So these are the two ways. So what they speculated, that it is a central mediated hypoxic hyperventilation system is actually affected and is abolished. What also they found that if they use erythropoietin antagonist, okay, the same thing is happening. If you take a erythropoietin antagonist and apply to this center, that is in the brain, in the medulla, and this hypoxic hyperventilation is abolished. So what they are speculating, if you use erythropoietin in a patient who is hypoxic, it can benefit the patient a lot. Like it can lead to neuroprotection, it can stimulate the central nervous system of the ventilation, it can protect the pulmonary endothelium, and later on you will find that pulmonary, as Dr. Sanjay has said, that pulmonary endothelium, not epithelium, pulmonary endothelium is the main culprit. Is a vasculitis is a main culprit. It is not, you can say, a infection, actual infection of the virus penetrating the parenchyma. Also, they found that if you use erythropoietin, it leads to a lot of red cell production, so it can combat the hypoxemia. And this erythropoietin has got anti-inflammatory effect. Now let's try to answer another question. Why some people are asymptomatic, whereas others develop severe symptoms? So in International Journal of Infectious Disease, they published a study from Italy. They had 3 groups, and what they could find, inoculum effect is coming to be one of the major, you can say, major variable, other than the old age, comorbidities, and male gender. We all know that whole world is behind the male gender, but inoculum is one factor which can affect some people, can lead to asymptomatic, other people which may be symptomatic, may land up in severe symptoms. What they could conclude, if you spend long time without SMS in a closed room, then very high chances that you will be actually facing good amount of inoculum. Same study was done by Wim Demi et al. And still this is not peer reviewed, but they found that they had some keen observation with the patient with a severe disease, especially when they found that there are 2 types of system, innate and adaptive immunity. What they found that patients who are having severe disease, the innate immunity also get affected, adaptive, innate, as there is increase in cytokine and chemokine level, we call it CSK storm. There is an altered neutrophil lymphocyte ratio. There is a lack of robust interferon 1 and 3 signature from the infected line. Primary bronchial cell doesn't actually manifest as a first line of defense by producing interferon 1 and interferon 3 signature. Also, they found that adaptive immunity also get affected, like patients usually have lymphocytopenia that influence the dose of the virus. Also, they found that total number of monocyte, eosinophil, basophil, and also total absolute amount of neutrophils was low in a patient with severe disease. Also, one interesting finding, they found that antiviral neutralizing antibodies were delayed. They appeared delayed in the severe patient. But again, one interesting thing, they found that there is a higher serum antibody level if the patient is suffering from severe disease as compared to milder disease. So whether it is an effect of cause, we don't know. They could define some prognostic markers of factors of severe COVID-19 disease, like age more than 55. We know that pre-existing pulmonary disease, chronic kidney disease, diabetes with HbA1c more than 7.6, history of hypertension, history of cardiovascular system, use of biologics. Of course, in severe patient, you're going to use biologics, especially weight more than 100 or BMI more than 30, and all patients with HIV, regardless of CD4 count. Also, they found that if saturation less than 90% in room ambient air, Of course, we understand that they come into severe category, and also they found that D-dimer, CPK, CRP, LDH, elevated troponin high, and admission lymphocyte, especially lymphopenia, they are categorized as a severe cases. Ultimately, what they could find that in a patients with high dose of SARS-CoV-2 initial inoculum, what is happening? There is a delayed activation of innate immune response. So if we call it this innate immune response, there is a lot of delay. And that time there is an elevated pro-inflammatory response and lead to cytokine response, cytokine storm. So what is happening in a patient, particularly who land up in serious problems, they have got delayed activation of innate response. So all these two studies could able to conclude, if you got a young people and if you expose them to low inoculum so that they develop immunity, this way you can develop herd immunity, and gradually lockdown should be open and in a closed way, okay? But this is not applicable to India because our elderly lives with us. If I am young, I'm 50, I still call myself young. If I am young and take up an infection, but I can become a contagion for my parents. So probably we cannot expose our young population to this virus also. Now the last question, why children are not suffering from severe disease? This is now proved wrong by appearance of MIS-C. But initially what they said that there is a decreased expression. This is A and this is B. A is pediatric and B is adult. Look at the A part. There is a decreased expression of angiotensin converting enzyme 2 and TMPRSS2. These are the two enzymes which are present in the airway epithelium. Also, they found that there is a relatively good number of CD4 cells and decreased neutrophilic infiltration. So there is a decreased neutrophilic infiltration here. Okay, so that's why their pro-inflammatory cytokines are less. There is a greater capacity to recover from the viral infection. That all we know that. Also, it has been found that endothelial apoptosis and dysfunction is less common. So less chances of leaky endothelium. So that's why in pediatric age group, the disease is less. But this was around 2 months back. This appearance of multi-system hyperinflammatory syndrome that is appearing after 2 to 4 weeks of COVID peak has baffled everybody. Okay, definitely it has given a lot of job to the pediatrics, especially pediatric intensivists. But look at the spectrum of this COVID-19 in various children and adolescents. This can be just a mild symptoms, which is happening with actual COVID-19 infection in pediatric age group. So you just give symptomatic treatment. There can be few of the pediatric patients, especially infants and adolescents, where they can have hyperimmune phase, which was happening in adult also, which was actually killer in the adult, especially with the comorbidity. Immediately after viremia phase, these as adult as land up in inflammatory, pro-inflammatory state. Same thing has been seen in few pediatric less than 1 year, some immunocompromised where viremia phase used to be prominent, and some adolescent like adult. Now, what is happening in pediatric? They have found that after 2 to 4 weeks of, you can say, a COVID peak, these patients are landing in multi-system hyperinflammatory syndrome. And believe me, this hyperinflammatory syndrome is much worse than hyperimmune phase of COVID, which was happening in adult and leading to disability in the lung. What is the major difference? Nobody knows. But major difference is that in adult, when we talk about hyperimmune phase, it is mainly affecting the lungs. It is a localized hyperimmune phase to start with. Now we know that it is not only affecting the lungs, it is affecting the heart, it is actually affecting the vessels. This way it is also affecting the kidneys. But 99% of the patient primarily has lung problem. Okay. And of course, their recovery is delayed, but also a lot of patients have tachycardia, a lot of patients have cardiovascular disability, few patients have CNS involvement. As compared to pediatric multisystem hyperinflammatory syndrome, it is not primarily affecting the lungs unless there is a fluid overload or there is congestive cardiac failure. That is secondary to cardiac failure. Patients are developing lung problem, but primarily it is not a disease of lung. It is leading to cardiovascular dysfunction as it was happening in dengue. Okay. Now, I couldn't find a lot of literature why this is happening, except that this one around 15 days back, this was posted. They tried to explain on the similar basis. This one, a child who didn't had hyperinflammatory syndrome, and this B, where the child has actually developed hyperinflammatory syndrome. What they say that interferon 1 and 3 are the most important ways the body fights with the virus. So appropriate interferon response is there, and it leads to inhibition of viral load, and there is a IgG antibody production in the both. So this way, interleukin-6 and chemokines are less in number. The patient have mild disease or asymptomatic. What we observed in these patients. Now look at the B number where actual patient develop this type of hyperinflammatory syndrome. What they found that there is a delayed interferon response, especially 1 and 3. So there is a slow viral clearance, and gradually over the time there is a more inflammation, and more inflammation means lot of cytokine. If you compare pediatric hyperinflammatory level of IL-6 and CRP, they are 50 times more in pediatric hyperinflammatory syndromes as compared to adult hyperimmune phase secondary to COVID. Still, pediatric patients recover very fast because they have got recovery potential. If you look at the D dimer, they are scared of D dimer of 1+. We are looking at D dimer of 15, 20, 30+. Still, these patients recover very fast, and most of the patient doesn't require thrombolytic therapy or heparin therapy. Okay, that is a marked difference between two types of inflammatory syndrome. One is multi-system inflammatory syndrome in pediatric as compared to inflammatory syndrome secondary to COVID infection in adult. Most of the patient in adult, once they land up in inflammatory syndrome, usually they clear up the viruses after say 9th, 10th day. And in pediatric also, in 90% there will be antibodies positive, but antigen or RT-PCR will be positive only in few of the patients. What is the definition of? I think the next speaker is going to talk about this MIS-C in detail, so I can skip and we can take question and answer. But remember, after 3 to 4 days of the high-grade fever, said it is 101+, these patients land up in hyperinflammatory syndrome. What is this hyperinflammatory syndrome? Mostly, they land up in typical rash over the face, over the eyes, what was happening in Kawasaki disease. A generalized erythema over the skin. Patient usually develop pain in abdomen, and suddenly their blood pressure starts dropping. So in 60 to 70% of the patients, they land up in ICUs. They have shock, cardiorespiratory, renal, gastrointestinal, and neurological involvement. But primarily, it is the low blood pressure, abdominal, gastrointestinal involvement like toxic shock syndrome. So it is a combination of Kawasaki disease and toxic shock syndrome with history of COVID in the family, or they are coming from contaminated zone. Their antibodies are positive in 90% of the patient. So it is something like a extended dengue. In dengue, we understand that after 4 days, they'll end up in this type of problem. So it is something like after 2 to 4 weeks, they'll end up in problem. Okay. So this is our data. Total, we had 23 patients of MIS-C. I'm not talking about COVID at all. Antibodies are positive in 19. And antibodies were negative in 4. Antigen RT-PCR was nil in all. There were no RT-PCR positive. And data I'm showing, we have analyzed only 9 because last around week we got lot of patients didn't got time to analyze. So feature which we found is a facial swelling, redness in eyes in almost 90% of the patient, mucocutaneous involvement in 7% of the 7 patients out of 9. And coronary artery lesion we found almost in 30% of the patients. And These are the, you can say, specific labs. You can see thrombocytopenia, elevated CRP marked, elevated CRP, even up to day 9, this is marked, elevated D-dimer, elevated interleukin 6, elevated pro-BNP, and troponin I. Even if your cardiac function on echo looks normal, they are very high. They are markers of cardiovascular dysfunction. They should be almost near normal before you discharge them, or there is no hemodynamically instability for at least 48 hours, only then you discharge them. What therapy we gave? We gave low dose methylprednisolone to 2. Otherwise, most of them have received IVIG and pulse dose methylprednisolone. We give pulse dose methylprednisolone if patient is having low blood pressure. And now comes the last part of the presentation. There's a lot of confusion. Which drug to be given? Should we give remdesivir? Should we give hydroxychloroquine? When we should give tocilizumab? So next few slides, I'm going to take you just about the, you can say, whole COVID infection, and you'll develop common sense and take my word. This is the simplistic disease presently in acute phase, which we all can treat. We don't need typical medicine physician, anesthetist, or chest physician. This is very simple disease to treat in 99% of the patient if you understand what is happening inside the patient. Let's start. This is probably the most important slide out of all. This gives you in common sense what we develop when we manage a lot of patients. Here the patient, this human being has acquired infection. After, say, incubation period of an average of 6 days, this is day 1 of symptom. We all know that 3 days before patient human become contagion. Whether it become patient or not, it is his luck and virus luck. So let's start our journey from the day 1 when patient has developed symptoms. So we know that this is a phase where the peak of viremia has happened. So some viremia was happening, but we are interested in this yellow one. So now viremia. After 7 to 10 days, this viremia will subside. Okay. Now, if this viremia, this antiviral drug are going to be useful during 10 to 12 days of start of symptomatology. So that is very clear. What are antiviral drugs? This is the remdesivir, favipiravir, or plasma therapy. As simple as that. If you want to give therapy after day 12, there are reasons, like if you're giving tocilizumab, then at times you give remdesivir, then because we know that there can be little bit viremia phase. But one thing is very clear. After 12 days of symptomatology, viremia phase subsided. So antiviral therapy doesn't contain any value. Okay. Patients usually have non-respiratory symptoms at this stage, like simple throat pain or coryza or pain in abdomen, loose motions. And also you'll find in CT scan also, there will be ground glass CT because viremia itself can produce, you can say, ground glassing in form of pneumonia. Okay, as usually we have a lot of pneumonias which create ground glassy appearance. Now we move from the day 7 onward. Day 7 onward, there can be possibility of 2 things. One is immune dysregulation, which can lead to this hyperimmune phase, can directly affect the lung, or it causes endothelitis. Endothelitis means endothelial inflammation. This endothelium inflammation leads to thrombophilia. So these are the 2 mechanisms, thrombophilia and cytokine storm, which along with viremia that hasn't subsided by 100%. These 3 pathologies leads to respiratory symptoms, which we see on the CT scan, that is ground glassing. Patient develops hypoxemia, can develop hypoxemia and desaturation. At this stage, we have got in mind that anti-inflammatory therapy has got a role, like steroids, or drugs like anti-interleukin 6, anti-interleukin 1-like drugs. Okay, why? Because thrombophilia and immune dysregulation are the 2 disease processes which are playing into the part. By giving anti-inflammatory drug, we want to subside the immune part, but the thrombophilia part, that is endothelitis, will be taken care by the that is D-dimer is, you can say, surrogate marker. So we will start heparin for this. So there are two drugs, anti-inflammatory drugs, and second is your the therapy like heparin, which will try to subside, try to decrease the endothelitis and the fibrin, you can say, formation. So in nutshell, there is a hypoxemia. Initial pulmonary phase, this is a prothrombotic state and hyperinflammatory state that is responsible for this hypoxemia. My target will be to reduce the prothrombotic state and to reduce the hyperinflammatory state. And what are the markers? CRP, ferritin, interleukin 6 gives an idea about hyperinflammatory state. Prothrombotic state, we come to know about the D-dimer. So what we can summarize, we have got two phases of pulmonary. You can say these are the lungs has been affected, and there are two symptomatic pulmonary phases that has been described. One is early pulmonary phase, day 6, day 7, patient feeling hypoxic, desaturation, you find on CT scan, on X-ray, there's a ground glassing. We call it, this is a low elastage or L phase, where the causes are viral infiltration directly, endothelitis leading to thrombin formation, and direct inflammation of the lung parenchyma. Okay, in this phase, you just give oxygen, give steroid, at the most do it prone positioning, give biologicals like anti-interleukin 6. Okay, this is very clear. This is a potentially reversible position. Now, if you don't take care of their comorbidity, patient is really hypoxic, patient has come late, you couldn't give anti-inflammatory drugs to start with, you delayed the procedure, patient was very obese, patient had a lot of comorbidity, especially diabetes, glycosyltrated hemoglobin more than 7.6, they'll end up in typical ARDS, which we used to see for decades. That is high elastase ARDS, that is known as H-type. Here you intubate, you increase the PEEP, titrate the PEEP, and actually what is happening, there's a lot of consolidation and pulmonary fibrosis are setting in this situation. Here nothing works except in a few lucky patients. Your high dose steroid may work. Now we come to the last part, that is the cases of Missy. Just I would like to run these videos. This was a 3.5-year patient on the left side. Look at the A1, and with hypotension, cardiac dysfunction, and behave like typical incomplete Kawasaki disease. Flush CRT is a classical in 90% of the patient. We used to call it warm shock. This is another patient, 4-year-old, high-grade fever for 4 days. Classical, look at that lips. It is red, charry lips. Patient had cold extremities, low blood pressure. This is another child who looked absolutely fine in emergency. Look at the child, A number video, and sitting comfortably. But we found flush CRT, patient had 104, 105 fever, and extremities looked fine. Your bounding pulses, patient had bounding pulses, blood pressure was 91/53, and saturation was absolutely normal. We took this patient to the ICU. Within 1 hour, this patient crashed, had blood pressure of 50/36. And look at the coronaries. In day 4 itself, coronary was enlarged, though ventricular function was normal. We started IVIG. Within 12 hours, this patient landed up in pulmonary edema. Look at the ultrasound. The patient is showing confluent V line. It started furosemide, and things got cleared up within 12 hours, though X-ray didn't show anything suggestive of pulmonary edema. So ultrasound is a very good, you can say, modality which gives an early idea. You can monitor your patient. Also, this is another patient, 9-year female with the fever for 3 days, high grade, severe pain in abdomen, increased irritability, developed shock, and was intubated. And look at the IVC, this is quite dilated. And the patient had almost refractory, you can say, blood pressure. Blood pressure did not increase for almost 2 hours. It stayed around 52 systolic and 35 diastolic, despite of giving high inotrope. It was a 9-year-old female. As I told you, ultimately, she also recovered. So recovery potential of these patients are very good, means fantastic. And there is normally very less mortality all over world. This is a very interesting child, a 17-year-old presented with fever, 105. Again, I am emphasizing higher the fever. I have found 102 plus fever is a red flag sign. 105 plus for 2 days, vomiting, admitted in nursing home. I think I have taken a little bit long time. I'll be finishing up in next 5 minutes. Hypotensive, shifted to intensive care with IV fluid, inotrope, ventilation, steroids, IVIG was given. On the 5th day, this child was improving. Her cytokine was going down, but she developed refractory seizures. Pupil became sluggish. Patient came to us. We found that on MRI, it was reported to have hypoxic changes. But we again reviewed it was actually Adam-like changes on the MRI. We gave plasmapheresis. Patient became fully conscious, but couldn't move limb when she became conscious. And actually, she also developed a man variety of Guillain-Barré syndrome. Now tracheostomy has been done. Patient is fine, and we are weaning off from the ventilator. I think it is stuck. I think next presenter doesn't want that it should move, so I can. Yeah, I think I stop here, but just 1-2 points I want to emphasize. Early diagnosis of multi-inflammatory syndrome should be made, and that has definitely had led to improved outcome in these patients. Any patient who is presenting with 102 plus fever, on 3rd day, especially if it is 4 years plus, at least try to rule out this type of syndrome, get 2 tests done. One is CRP with blood counts and COVID antibodies. This will give you an idea what is happening inside the child. Most of the patients, as our data says, that on day 3 plus, they deteriorated. Though we had patient, around 3 patients, which I didn't include it in my data, they deteriorated on day 2 of the illness. So rather than just telephonic counseling, ask them to come to emergency, and almost 50% of the patients were just counseled on the telephone. And somehow, as we were also just doing telephonic counseling 2 months back, now this is the time that we should come to the emergencies and have a look in those patients. So just one point I want to make on the adult and adolescent. COVID management is just a common sense management. You require not only clinical skill, but these patients should be investigated properly. So it has to be clinical, pathological, you can say inflammatory markers should be chased till they recover fully. Don't neglect them. These patients are on steroid. You will not have an idea. They are actually silent hypoxic. You are suppressing inflammatory marker because of anti-inflammatory drug. You try to not wean them, try to discontinue anti-inflammatory drugs, despite everything was going fine. Within 24 hours, I found especially patients who are 60-year-old with comorbidity landing in irreversible lung damage. There were many slides related with the cardiac problem post-COVID, lung problem, that is pulmonary fibrosis, but still we didn't have an answer. But remember, last point what I want to emphasize, any patient who is developing hypoxemia, give steroid as fast, as early as possible. Remember, if you try to give steroid, that happened with one of our colleagues, he was given steroid too early. He was given tocilizumab too early because probably the people around were, too hyper about the disease. And there is increase in mortality by more than 3 times if you give steroid during viremia phase. You have to recognize that window. That window, my experience as per the knowledge which I have acquired from my adult physician by treating the patient, starts normally around after 5 to 7 days of the disease process. If patient is persistent to have high-grade fever, especially more than 102, I'm talking about COVID. I'm not talking about hyperinflammatory syndrome. I'm talking about adult COVID, because in this pandemic, we are worried about ourselves also, our near and dear also, more than just our patient. If fever has got biphasic, to first 5 days fever is there, no fever, then fever again comes. These are high-risk patients. Fever with chills and rigor. patient who is feeling little bit dyspneic, though you cannot say respiratory rate is more than 24. These are high risk patients which should be investigated properly. These investigations should be repeated every third day, despite they are feeling absolutely fine. They feel this is a waste of money. Still, in high risk patient, this should be repeated every third day till clinical as well as inflammatory marker get subside, and taper the steroid for not less than 10 days in high risk group patient. Thank you. Thank you very much.
Thank you, Dr. Dhiren. That was an excellent presentation. Can you hold on for some time? We'll have the questions after Dr. Dinesh's presentation.
Sure, sir, sure.
So I think we'll go ahead with the next presentation. Dr. Dinesh Chirla, my good friend. He is MD Pediatrics and DM Neonatology. He's associated with Rainbow Hospital since a very long time, and he's one of the top echelons there. He is the Director Intensive Care Services and the head of the Department of Rainbow Hospital. He is interested in neurocritical care and advanced ventilation. He has more than 25 published papers internationally. Whenever I have a problem, I raise my hand, and Dinesh is always there to pull my hand and save me. Over to you, Dinesh. Thank you so much.
Thank you, sir. Thank you for the kind introduction. Good evening, everyone. And at the outset, let me sort of acknowledge that this presentation has been done by Dr. Farhan. Unfortunately, for some unforeseen circumstances, he could not present this. So I acknowledge that it is all his hard work. He has assimilated all the data and done this presentation. I also sincerely thank all my colleagues who have worked very hard, Dr. Parag, Dr. Kapil, Dr. Anupama, all my PSU colleagues who have worked very hard during these COVID times, and especially the nurses and the team. So this talk is dedicated to them. And so after the excellent presentation from what we heard from Dr. Dhiren Gupta about the challenges which we are facing with the current COVID, both from the adult side and the children's side, what we thought is, let us share what we are facing currently in Hyderabad. Because what Delhi faced 2 months back, I think that's what we're seeing in Hyderabad now. If you look at most of the adult hospitals are now full, they do not have beds. We're worried most of the ICU beds are sort of filled, many of them getting sicker. One good thing which we see is that fortunately the children are not seriously affected. Even you look from data from different countries, they constitute around 5 to 7% of the total number of cases who are positive. But one thing which is affected with children, which has been documented in China, UK, Italy, US, is that the multisystem inflammatory syndrome, or some have coined as pediatric multisystem inflammatory syndrome. And this is something which we are seeing, and we already started seeing that quite a few cases in Hyderabad. And that is what I'm going to share. What are the number of cases we are seeing and what we have been managing. This we have been managing along with our RCHI colleagues, Dr. Nagesh Rao and his team. If you look at the definition, partly going through what Dhiren has nicely presented, is the RCHI, WHO, and CDC has almost come with similar definition. And what is common in that, they're talking about adolescents and children. So some have said less than 19 years, some have said less than 21 years. Fever is common, so all of them have high-grade fever. Inflammation is common. So you have a documented neutrophilia, elevated CRP, you have lymphopenia. There is evidence of single or multi-organ dysfunction, which could be in terms of shock, a cardiac involvement, a respiratory involvement, renal, GI, or neurological involvement. With evidence of either you're getting an RT-PCR positive, or you have an antibody evidence, or you at least have a history about being an exposure to somewhere who has got COVID-19 positive. So there's not necessary that, if you look at some of the studies which I will share, Not everyone had definite evidence of both. Similarly, from multisystem inflammatory syndrome of COVID, the WHO has said, now WHO has included the 19 years as a cutoff, a fever of more than 3 days, and having a rash or a corpulent, any of the two, like conjunctivitis or mucocutaneous inflammation, which Dhiren has showed a lot of his patients had, presence of hypotension or shock, feature of myocardial dysfunctions or pericarditis, evidence of coagulopathy, acute GI symptoms. So GI is something. So that is one thing which is very different from what we are seeing from the adult is a lot of GI involvement, and which I'll show, which we have also seen the cases which have admitted. Elevated markers of inflammations. There are many patients we are getting with very high inflammatory markers and without any obvious cause of inflammation. So you have documented there's no bacterial sepsis, there's no staph sepsis, there's no streptococcal shock syndrome. And as I said, evidence of a COVID. Now they have been categorized into 4 different things. So one is a fever syndrome without shock, without Kawasaki disease. So this is one syndrome. So you have fever with elevated inflammation. So there is a fever with a GI or respiratory symptoms, may or may not have an abnormal X-ray or may not have abnormal CT, but there are elevated inflammatory markers. So this is a category 1 which we are seeing. So there is high fever, very high inflammatory markers with COVID positive or past infection. So there is an antibody present, but here, mind you, there is no shock, there is no Kawasaki disease. The second category which you're seeing in this is you have a multisystem inflammatory syndrome with Kawasaki disease, which means you have a features of coronary artery dilatations. You may or may not have all the features of Kawasaki disease, which is you have a nice video which shown by Dr. Dhiren where there's a, the lips are all inflamed, you will have conjunctivitis, you will have those features to coronary artery dilatation. So definitely documentation of coronary artery dilatation. So you have a Kawasaki disease with shock or without shock. So that is a second category. And third category is you do not have features of Kawasaki, but you have a child presenting with shock, typically presenting like a septic shock or cardiogenic shock or toxic shock syndrome, but there you do not have any features of sepsis. There is a evidence of COVID-19 in these patients. So that is how they're presenting. And of course, the fourth category is typically COVID positive, but no evidence of any inflammation. Now, I'm talking about this about our pediatric experience and not about neonatal experience. We had quite a bit perinatal experience of COVID also, which I would share sometimes later. But I think here I'm talking purely about our pediatric experience at Rainbow Children's Hospital, Banjara Hills. So we had total 66 patients till July 2020. So in August also, and as Dhiren rightly said, in the last sort of couple of weeks, we are seeing a lot more cases. And I expect that what Delhi is seeing now, in probably the next 1 month, we might see a lot more cases in Hyderabad, because this is a delayed inflammatory response. If you look at from the adult, you have an acute inflammation, which is nicely shown on the slide, which is I think still there on the Dhiren's, this thing, where is an acute inflammation response at the end of day 7, which we can see. Whereas what children are showing is a delayed inflammatory response, which is typically seen at the end of 2nd week or 3rd week of infection. And this is what is the pediatric multisystem inflammatory syndrome. So 66 patients of COVID has been seen, out of which 29 showed multisystem inflammatory syndrome. 6 were having category 1, which is they had evidence of inflammation, but didn't have Kawasaki disease, didn't have any shock. 10 patients had features of Kawasaki disease. With shock, few had without shock, I'll share with that. And 13 patients had no Kawasaki disease, but had shock. And there are 37 patients who were COVID positive without any inflammation. Out of the 66 patients we had, 51 patients had RT-PCR positive. Now, there's always a question is why the delayed inflammatory reactions will still have an RT-PCR positive. There are different theories about it, either they are delayed shedders or sometimes some dead antigens are also giving positive. So these are some of the theories for saying why we still have positive. And when we looked at some of the studies which are published in the pediatrics, you still find something similar. Out of the patient with multisystem inflammatory syndrome of 29 patients, 14 had positive. So less than 50% were positive. 10 had antibody positive. 2, we couldn't have either antibody or PCR positive. And in 3, we were not able to test because the antibody testing was available in Hyderabad a little later. But the child has all the features of that. We analyzed our results into these categories, and as been rightly pointed out, even if you look at adult or in the pediatric, which has been documented in other studies, somehow the boys seems to be a little bit more affected in this group. Unlike the Kawasaki disease, which affects children on the younger age group, this seems to be affecting children slightly the older age. The classical day of presentations typically has been day 3 to day 4, and sometimes little later. There have been children with comorbidities. If you look at children with multi-inflammatory system syndrome, we had a lot of children in the 5 to 10 years and 10 to 15 years age group. That is nearly 18 children out of the 29 were in this age groups who had shown the multi-inflammatory system syndrome. And obesity was one of the risk factors in them. Comorbidities definitely played a role. We had children with 2 children with chronic liver failure and of course, and they didn't do well, and we could not save them. And I think the added feature of shock with chronic liver failure said it didn't help them. But children post-liver transplant, hemophilia, trauma, epidermolysis bullosa, tuberculosis meningitis, they all made it. A lot of these children had come in very sick with a PRISM score of more than 10 and SOFA score of more than 8 to 15. There were a significant number of patients who were quite sick. There were 2 children who also had associated dengue illnesses. And also one child who had E. coli urosepsis. When we looked at what are the common symptoms, almost majority of them had fever as a presenting sign. So except for I think few, everyone had fever as a presenting sign. Only half of them had cold and cough or respiratory problem. And also nearly 40% of them had GI symptoms, which is what has been strongly sort of seen from the other also. Conjunctivitis was more common, I'll show in the next slide, in the Kawasaki disease group compared to if you look at the overall group. And hypotension was very common in the shock group. And myocardial dysfunction, seizures was present in 3 patients out of the 29 patients. And a lot of children were initially encephalopathic, but they quickly sort of recovered. If you analyze this in the category B, this is the way you would find that you will have children with conjunctivitis more, rashes were more in these children. You had majority of the children with shock here, and myocardial dysfunction was common in all of them, and they were also because of the encephalopathic because of the shock. When you look at the lab results of this, so COVID PCR was positive in 14 of them, and antibody was positive in 10 of them. And it didn't make a difference with the categorization. And we got positive contact history and in majority of them. And there was a definitive positive contact history in, even if you take the category 4, which was only COVID positive patients who had other respiratory problems or they were also sort of, but there we didn't do the antibody test because they presented acutely. The CRP has been significantly elevated in all the patients with multisystem inflammatory syndrome. The procalcitonin was also significantly elevated, so was ESR and interleukin 6. The ferritin was quite high. In fact, now we have a child who has a ferritin in 30,000, 40,000 also. The D-dimer, I think, I don't know, the D-dimer has been significantly high in a lot of patients, and they have been sort of have to put on enoxaparin. Among children, if you could see in the category 2 and 3, the troponin level and the pro-BNP levels, which would suggest about myocardial dysfunction and the heart failure, were significantly high in this patient. So these are the patients who presented with shock. We did the troponin level and pro-BNP level, and they were significantly high in these patients. The key in management of this patient is to try to diagnose them early and initiate treatment. X-rays was normal. So I know fortunately in children, I think lungs don't seem to be that badly affected. So, which has been sort of documented in many of the series of children series of COVID-19, which has been presented internationally. There have been bilateral or unilateral involvement, though some cases we have seen pleural effusions. On cardiac evaluation, if you see, especially in the category 2 and 3, that is in Kawasaki disease, and in the non-Kawasaki one with shock, LV dysfunction was a significant finding. All the 10 patients who had Kawasaki disease features had dilated coronaries. And one of the things Dr. Nagesha was saying, he never saw such giant coronary aneurysms. They presented such a giant coronary aneurysm. That is the reason why now, as clinicians, we have become very aggressive in evaluating these children and in fact initiating immunomodulatory therapy in them, because looks like these children sort of are at high risk of developing coronary artery aneurysms. Because earlier, in the first one case or so, we thought we'll go a little slow, because just as we all are in the learning phase for try to understanding the disease. But very much on the second week, he saw such a big aneurysm. He said never saw coronary aneurysm like this big. So LV dysfunction is a significant finding in a lot of them. It takes quite some time for the ESR and ferritin to settle down. And you could see the dilated coronary arteries here. Now, if you look at the management strategies, category 2 and 3, say in Kawasaki disease swim, there were 70% had features of requiring fluid boluses, and some of them required inotropes. Whereas in category 3, all of them required sort of fluid boluses and inotropes. And whereas in category 1 and 4, it was sort of one-off patient which needed that. Interestingly, we had to give steroids in majority of the patients in category 2 and 3. And we find that helped. And as rightly forward, you see, what we see compared to adults is if you look at, see, there are in Telangana, whatever, that is something which all the pediatricians are finding, is that most of the pediatric patients with COVID, whom we are seeing, are contacts of adults who are COVID positives, and they're happily playing at home. So you're basically doing home monitoring of these patients, and nothing is happening to them. Sometimes they're having mild cold, no other symptoms are there. So really, you don't have to, the need for antiviral has been really, really insignificant in them. I think we stocked in a lot of antiviral, and I say we had to hardly use any antiviral in a lot of pediatric patients. Most of the time, what we as a pediatrician are needing is immunomodulation at later stage, because what the children are behaving is the delayed immunity response. That is when they're getting sicker. And once they start showing evidence of coronary dilatations, that is when you have to be aggressive. Or when you're showing features of Kawasaki disease, you have to be aggressive in giving IVIG. Somehow we haven't given high-dose pulse-dose methylprednisolone as of now. So far, we haven't seen. Maybe in future we might start seeing, because there have been adult experience about people presenting like what Dhiren just now showed about patients present with Guillain-Barré syndrome and other things. So we may be happy looking at that, because Delhi had seen a surge of, and that is something people have seen, is 6 to 8 weeks after the peak of epidemic of COVID, that's when a lot of children with pediatric multi-respiratory system syndrome is seen in PICU population. Only one patient. So we haven't jumped to any of these immunomodulators or IL-6 anti medications. But a lot of patients did require enoxaparin. As I said, the D-dimers were significantly elevated, and we used aspirin in all the children who had Kawasaki disease. Remdesivir was used in one child who had features of shock and severe lung pneumonia. So they are the patients whom we had to use. So as these are the children, fortunately, the lung doesn't seem to be that badly affected. If you look at the number of children who are needing respiratory support, nearly half of them, a little less than half. So 10 of the 29 are needing respiratory support. That is HFNC, CPAP, or HFOV, or this. Most of them we managed to give with non-invasive support and try to get them off. Only one needed HFOV, and I know a couple of the babies required CRRT therapy, but majority of them have been managed sort of with minimal support. What they definitely needed is a lot of inotropic support during the acute phase, and definitely steroids made a big difference to these patients. The average stay in PICU has been approximately around 4 days. The stay in the hospital has been anywhere between 7 to 10 days. Majority of the patient, all the patients in category 1 and 2, and except for one patient who went lama in category 4 had died. That too, the child had refractory, super refractory status because of poor parents went home and this thing. There are 4 children in category 3 with bad shock who had come in, who could not make it. And as I said, out of which 3 of them had severe comorbid factors like chronic liver failure, who are waiting for liver transplants. And that is why those patients could not make it. And otherwise, if there are no comorbid factors, and if you initiate treatment on them early, they all sort of tend to sort of recover well. If you look at the data series from around the world, and when I looked at the series, there are 28 children, which is to be published from Boston Children's Hospital. There is from one center reported. If you looked from a case series, which has been reported from UK, Italy, France, and Switzerland, there are 70 children. And from 8 hospitals in UK, there have been 15 children who have been reported with pediatric multisystem inflammatory syndrome. Again, they also found that boys were 66%, girls were 34%. Only RT-PCR were positive in 26% similarly, but they had majority of them antibodies were positive. In Hyderabad, antibody became levels were test was available a little later. There was nearly 80% of the cases, there was a current or prior sort of exposure to COVID infection. All the children had fever or non-specific, and they had symptoms like, as you said, nearly half of them had abdominal symptoms. Rash was present in, especially those with Kawasaki, they were present with rash or conjunctival injection. All of them had elevated CRPs and elevated ferritin, nearly 53 out of 58, which was also seen in our case. And if you look at this, very similar to our 29 out of 58 developed shock, which is what we saw in multi-inflammatory system syndrome. 23 received mechanical ventilation out of 58, which means not everyone, very few, most of them will have sort of, inotropic support, but they will otherwise will recover. Out of 58, 13 had features of Kawasaki disease, where 23 other had fever inflammation without features of shock or Kawasaki disease, which is what we also found. And 8 patients had developed coronary artery dilatations. This is the beginning of this. So far, we had 2 cases, and I'm sure there are, we are going to see a lot more cases in future. So what I had to give a message is that in state of Telangana, with rapidly increasing sort of cases of COVID overall in adults, though fortunately we are not seeing sick respiratory cases in pediatric cases, we probably are going to see more of pediatric multisystem inflammatory syndrome in the next month or so. Be vigilant about it. Look for all the possible categorization, whether it is only fever, whether it's just a inflammatory syndrome without shock, is a Kawasaki disease with or without shock, or a child with shock is there. Initiate therapy early, and they all recover well, unless there are severe comorbidities associated. Thank you, and I'm ready for questions.
Thank you, Dr. Dinesh. Wonderful presentation, especially data on the local data. We are, I think in the last 43 webinars, what we had, more than a half a dozen webinars were there on COVID actually. But this was one of the best because it came from the best frontline workers on COVID. Dr. Dhiren is there, Dr. Dinesh is there. Dr. Dinesh, your exposition on ventilating the clinics, on the inoculum effect, cause of silent hypoxia, and on the principles and concepts of care was fantastic. Dinesh, we are proud that you have collated all data from Hyderabad, and we are fortunate that Rainbow Hospital has its prominent presence in Hyderabad, and you are there for us. So we'll start taking questions. Before I ask, I was told even before the talk that Dr. Satish Ganta had 2 questions to ask Dr. Dhiren Gupta. Dr. Satish Ganta, if you are there around.
Yes, I'm there. Can you hear me?
Please.
Can you hear me?
Yeah, we are able to hear you.
Yeah. Thank you, sir. Thank you.
You also.
Okay. Yeah. Thank you. I mean, the talks were just superb. And Dr. Dhiren, you are a walking encyclopedia. Amazing. And Dr. Dinesh, your talk was great as well. This thing is, it's current. It's today morning. So total, just to let you know, ours is a 100 beds children's hospital, intensive care, and till date, we have about 62 cases. And I haven't done the categorization as yet. Now, today morning, afternoon, we've had a child. He's a 19-year-old boy with a hypodysplastic kidney, and he's had recurrent rejections of his kidney transplant, which he had in 2016. So he's a 4 years old renal transplant. His baseline creat is 1.6, 1.7. His GFR is around 35 because he's about 60 kilos and 161 centimeters. Now, the issue is he has chronic allograft nephropathy, and post-transplant, he developed diabetes mellitus. He's on insulin. Now, he's on immunosuppressive drugs like steroids, MMF, and tacrolimus. Now, Dhiren, my question to you is, he presented this morning with a history of 6 days fever, respiratory distress since yesterday, and presented in the ER today morning in respiratory failure, had to be intubated and ventilated. So he's got obviously respiratory failure, DKA. He's on adrenaline infusion. So we don't have the COVID sort of markers, in the sense the cytokine markers until now. My big doubt is, see, he's on the big guns now. He's on meropenem, the renal dose, and vancomycin. And I hope Mehul is online as well. He's also listening. I hope you know Dr. Mehul Shah. He's a pediatric nephrologist. He's been managing the child all along. So my worry is, today's bloods are hemoglobin 13, platelets are 3 lakhs, CRP is 60, total count is 15,900, neutrophils are 85%, and lymphocytes are 6. Now, IgG, IgM, both are strongly positive. Today they said they wouldn't take the RT-PCR, so it might be positive tomorrow. Now, this thing is, we had to give steroids. We had to give methylprednisolone in our usual protocol. It's 10 to 30 milligrams per kilo as a pulse dose. So me, Mehul, everybody, we had a lot of discussion as to how about going, in this child who's got multiple comorbidities, every single organ is involved, and he's on meropenem and vancomycin as well as the renal dose. Now, we bit the bullet, and we actually gave 500 milligrams now with a plan to give it tomorrow morning, afternoon. Once we get the sort of the inflammatory markers, then we want to sort of maybe downgrade or this thing. So could you please throw some light on this, number one? Number two, because this is an acute illness, I know the LFTs are okay, but the coagulopathy is bad. INR is 3.3. So can we give remdesivir, or is it not indicated now? Not today, maybe tomorrow, day after. And third thing is there any role of IVIG early today instead of tomorrow getting the bloods? That's my first question, is about methylprednisolone, please.
Yeah, sir, I'll start with the second one. We
Yes.
always choose the easiest one when we used to do exams. So second one is, if this patient comes to be RT-PCR, so we have to define whether we are dealing with acute viral crisis with cytokine storm.
Yes.
Or is it actually a post-COVID hyperinflammatory syndrome?
Because the history is short.
6 days. I'll take the previous data also.
Yeah.
See, remember, you are passing through acute phase of COVID infection in that area. Okay.
Yeah.
Actually, I doubt if somebody says that without peak happening a month back, all these are actually post-COVID MIC.
Yes.
Okay. So there's a lot of confusion. Is it an acute viral infection following that a short hyperimmune phase?
Yeah.
It is happening?
Yeah.
Or actually it is a typical MIS. This is a totally inflammatory process when viral infection has subsided.
Yes.
And RT-PCR is just a bystander in some of the patient, and you are getting hyperimmune phase, a extended hyperimmune phase of adult type, which is a generalized hyperimmune phase, not limited to the lung.
Yes.
So I will link your second answer with the Farhan, cases.
Yeah.
if you look at the antibody positivity, if you look rule out those 3 cases were diagnosed when antibody was not possible, you take out those 7 cases out of that. So if you take out around 50 cases where RT-PCR is positive, but antibodies are not positive, so you will have doubt that whether actually they were MIC, typical MIC, or just a COVID infection with hyperimmune phase.
Yes.
So this way the management is going to be same.
Same, yes.
I will be because we are collecting data all over India.
Yes.
So our main aim is that we should not, over collect the data, and we should not under collect the data. So my feeling is that unless antibody is positive, that is happening, that will happen in 90% of the patient. Presently, we should not label them acute MIC unless it is happening with the peak. Means peak has happened 4 weeks back, and now you are getting patient of idiopathic variety where dengue is not there, where staph septicemia is not there. I may be wrong in long term, but present thinking, because we are passing through that phase.
But the IgG and IgM is strongly positive here.
Yeah. Now I come to your case. Your case. I'm just giving the thought process. MISC is different from a acute viral with hyperimmune phase.
Yeah.
Now we come to your case. If your patient shows RT-PCR positive, because that is unlikely, you have got antibodies positive. When first antibody usually appear at the most around 7th to 10th day. That time, usually RT-PCR or actual infectivity of virus goes away. So unlikely that you should land up in giving remdesivir. Second, there is a possibility because your patient is immunocompromised. I had around 3 patients who were immunocompromised, who had lung infiltration behaving like acute viral infiltration secondary to COVID, but didn't had hyperinflammatory response.
Yes.
These patients land up in respiratory failure. In these patients, because they were all immunocompromised on chemotherapy, you have to give remdesivir.
Yes.
Now in your patient, we have to define, is it a hyperinflammatory response or actual viral infection?
Yes, very true.
Now looking at the benefit and drawback of remdesivir, if your liver enzymes are not that bad, more than 5 times or not increasing, so you can give 1 dose of remdesivir because your child is very critical. You cannot experiment, and presently in your area, it is the peak of viral infection, not post-COVID viral infection.
Very true.
So 1 dose, I think I will give to this patient, and especially if liver enzymes are not more than 5 times.
Liver enzymes are normal. Only the coagulopathy is there.
I would like to give liver remdesivir to this child. He is totally immunocompromised. There will be hardly any clinical markers which will guide us to manage this patient. Yes. Unless we get IL-6 and all these markers every 6 hours. We are fortunate that every 2 hourly we can get these markers, but definitely this is one of the handicap. Now, first one, regarding methylprednisolone, of course, with the antiviral drug, you can go ahead with this cytokine, because most of the patients who are not immunocompromised, viral infection hasn't killed even a single adult patient most of the time. It is the post-viral immune phenomenon that has killed, so we should give steroid. Third point.
30 or 10? 30 or 10?
Sir, I will say, means that depends on how sick, how the blood pressure and everything. Wherever there
single inotrope.
Where the blood pressure is low and critically low, we give 20 to 30. We round it off, like something 20, 25. It is something like 500 milligram over 30 minutes. Yeah. So we round it off.
Yes.
Or if blood pressure is stable, then you give 10 milligram per kg, because we are into fix. Is the viremia phase or post-viremia phase, or it is only hyperimmune or no viremia? So we means 10 milligram per kg should be fine.
Yes.
Third point was
IVIG.
IVIG you should give, sir. IVIG, especially in pediatric. Now there is a problem. I try to get an answer. In adult, there is no role of IVIG. Nobody has given IVIG over past 3 months. And here the drug MISC, the drug of choice is IVIG. So I went into pathophysiology of MISC and viral hyperimmune immediately post-viral. I tried to explore this. And I spent almost 5 sleepless nights to explore this only. Why IVIG is not a drug of choice in adult when it is a drug of choice in pediatrics. Means I'm not, means I got very mediocre brain. So I tried a lot. What I could gather, there are different type of enzyme, there is cytokine, IL-1, IL-6, TNF blocker, TNF, and there are multiple. So whenever super antigen mediated disease is there, like toxic shock syndrome, like Kawasaki disease, then IVIG has got major role. Whenever there are just cytokine mediated role, then anti-inflammatory role. This I could, place in my mind fourth layer. Otherwise, still I ask lot of rheumatologists, they are in fix regarding, they are still confused about Kawasaki disease. Now the new review says that don't use word Kawasaki disease for MISC. MISC is different ball of game as compared to Kawasaki disease. Coronary dilatation can be found in non-Kawasaki disease, acute inflammatory condition. So beware of, you can say comparing these two terms. MISC is MISC, Kawasaki classical is different. Now we are in fix presently. We have got a 3-month-old baby who presented 12 days back. Few of the slides, I couldn't show, but that patient presented with interleukin, almost interleukin 6, 2000 plus, D-dimer of around 15. One is a normal, pro-BNP 25,000, and with coronary dilatation of around 7 Z-score. We have given IVIG, we have given high-dose steroid, and we have landed up in giving this one, Remicade. Yesterday we have given Remicade. Now antibodies are negative. Can we say this is post-viral? A Messi syndrome is a variety of Messi syndrome, or it is a typical? So presently, means everybody is confused, but for 3 months, what I could make up my mind, if antibodies are positive, if patient is coinciding with the peak after 2 to 4 weeks, these are classical Messi. Otherwise, it is a confused Messi. Later on, we can segregate, say, 4 weeks down the lane. If you find, okay, now antibodies are emerging in these cases, probably these are classical Messi. So I mean to say, we should also take all these Western data with pinch of salt, because they are not gods. When they started, they make their protocol by knee-jerk reactions. Nobody has done research in these patients. They are just less than 1,000 patients all over the world. So because they are saying that this is a drug of choice and this should be given at the first instance, they start IVIG when patient arrives in emergency. It takes, in the best of the setup, to have 2 hours or 4 hours to procure those IVIG. A costly IVIG drug, to convince them to give to a 100 kg man 100 gram, that is a lakhs of rupees. So I mean to say, what I have found, you give steroid when patient comes in hypotension, give fluid cautiously, they are fluid refractory, and give IVIG slowly once patient is in, because I've seen 2 patients landing in pulmonary edema because of the protocol.
I saw that case.
Yeah. So we are learning, things are evolving. And what I can say, I think you need to give all 3 in your child. It is very sick patient.
I think Dr. Satish, 2 intensivists talking.
Yes, sorry. Okay, I'll only one. Can I spend only one? Can I get one more time for one more question? I have to skip it.
Sir, we can take afterward. Can we have simple one from
I think we'll have some simple ones so that the audience gets.
Very true. Sorry for that.
Then probably 2 intensivists can speak with each other.
Yeah.
I am also sorry, sir. I went into cellular level.
Dr. Dhiren, the best part of your presentation was that use common sense approach when you are treating. That was the best part, this thing. One question to you, which I foresee is, there are so many modalities and protocols for treatment. How much is the treatment related mortality with COVID?
Sir, it's very difficult to give answer, but definitely over treatment, under treatment, both are bad. And if you try to give those arms and ammunition, you try to use those arms and ammunition before that window, Means recently there is a death in pediatric population, and I was told that some of the drugs were used too early, some of the drugs were used too quick and too fast. So I'm not commenting because I'm not a treating physician, and we should not comment also. But in general also, when I just read around few months back didn't work, then I was little bit more hyper. But when I started working with adult patients, I found that 99.9% of the patient just settle with simple steroid. Nothing you have to do. This application has to be for only 0.01% of the patients.
Yeah,
I have done mistakes, and this way I have drawn my protocol in my brain. So I work very cautiously, but try to avoid over treatment. Drugs like biologics, like tocilizumab, and these drugs should be given very cautiously. There is very high risk of infection. Whether patient dies of cytokine storm or not, I don't know, but they definitely die of infection, especially elderly patients.
A quick question: what is the role of oseltamivir? It's a question from the audience.
No, sir. It was few months back when nothing was there. Yeah, like you give antibiotic, all sort of antibiotic to everybody. So this is a broad spectrum antiviral. It has no role. It should not be used unless you are thinking of influenza and you don't get the report. Patient will end up in ARDS. Like it is going to happen over next 6 months. This coronavirus is going to be part of DD. As influenza, dengue, and your scrub typhus as other infection.
Positive.
Sir?
It has no role once RT-PCR comes positive.
Yeah, there can be, two diseases like RT-PCR, maybe bystander, and patient is actually case of influenza. So again, you have to use your common sense as per which season you are working, what type of patients you are getting, which are dominating patient, and you can use if you are thinking as on a broad spectrum, but don't think it is an anti-corona. That is very clear.
A quick question: for mild cases, steroids, yes, no?
No, mild cases. If mild cases, ask him to run or to work out for 5-6 minutes. If saturation is dropping more than 4, or saturation, baseline saturation is less than 95, and patient, this test cannot be performed. This test has to be performed only when saturation is more than 95. So
there is one more question.
Mild category should not be used. It should be used as a moderate category. Get all the tests done and get a dose of steroid.
Another question: preference between methylprednisolone versus dexamethasone?
Sir, either of it. If you are not admitting, then Dexa is better. And if you are admitting, if doctor is comfortable with methylprednisolone, you can use methylprednisolone. I usually use Dexa in adult patients.
There is one more question: CT scan when? We have seen thousands of HRCTs being done in Hyderabad. CT scan, HRCT when?
Yeah, sir, CT scan should not be used in all the patients. In a patient where you are thinking of other differential diagnosis, you are confused about the differential diagnosis, definitely. Like suppose a patient land up in 7th day with hypoxemia, RT-PCR negative, you are confused whether it's a corona or something like, definitely you would like to use. Or if patient, you are thinking of a complication in the chest which has happened because of COVID, then you can think of, and one more point I would like to add, use an ultrasound. My thought process, past 5 days I spend in, can I differentiate a patient moving from early pulmonary stage to late pulmonary stage ARDS? Can I use ultrasound? Because this patient won't allow me to take this patient to the CT scan. If on CT scan, the you can say opacity is to grade of 9 to 12. That is that a radiologist defined. Then your patient, instead of early pulmonary stage, that is a reversible pulmonary stage, is going towards consolidated ARDS and fibrotic stage. Fine. So this point is very important to prognosticate. Second, I try to jump in the ultrasound. Nobody allowed to take the ultrasound machine. Kharab ho jayega, ganda ho jayega. Nobody allows that. You can clean it later on. What's the deal? You put an ultrasound machine. If you find, instead of just B line, signs of consolidation there, then probably you start thinking that you are landing in late pulmonary stage. This patient is not going to recover very fast.
I know, Dhiren, you are one of the pioneers for point of care ultrasound focus. Now, there's one quick question to Dinesh on role of aspirin and low molecular weight heparin, enoxaparin for Miss C.
See, children with dilated coronary classical Kawasaki-like disease, I know there have been a lot of discussion about differentiating MISC-C, multiple inflammatory syndrome, COVID versus Kawasaki. We put them on aspirin. But if in present, a lot of children we are seeing with quite elevated D-dimers. So if you have associated quite elevated D-dimer, they are the children we are putting them on enoxaparin till they normalize and then continue with aspirin like the way we do with Kawasaki. But these are children specifically with dilated coronaries.
Dinesh, have you an answer for how long aspirin?
So we give typically we give the high dose till your ESR settles down and fever settles down, and then the child is shifted to 3 to 5 milligram per kg. They give it for 6 weeks and then stop it afterwards. And enoxaparin, as I said, to D-dimer.
Aspirin, you have an answer?
So, sorry again?
Dhiren, question to Dhiren, how long aspirin?
Sir, I'll define means I have written a protocol on the adult, pediatric and MISI also. I almost used 40 references, 40 protocols. So anti-inflammatory like high dose aspirin, what Dr. Dinesh fantastically, 24 to 48 hours afebrile, then you give low dose. Regarding low molecular weight heparin, I thought of that, can we chase D-dimer as has been done in adult? But what data says that if your child is obese, if your ejection fraction is constantly less than 35%, or if your Z score is more than 10, then you use aspirin, not aspirin, that is low molecular heparin. So these are the defined, but definitely, as I told you, nobody is God. No data is, can guide you. Means, in fact, what Dinesh presented a fantastic data that can become a role model data. Okay, these things can be given in these patients. So presently, what I could find, these are the 3 indications of giving low molecular heparin for around 2 to 4 weeks till things subsides or till your ejection fraction normalized. If somebody is having thrombus, then 3 months post thrombosis, thrombolysis, you can say normalization of vasculature.
See, one of the reasons I think one of the cardiologists have been seeing, looking at the giant coronary aneurysm which they have been seeing, that is one of the reason this recommendation is coming from the cardiologists, pediatric cardiologists, saying that they have never seen such aneurysms, and that's the reason they're recommending enoxaparin till the D-dimer settle down.
Perfect. Quick question from the audience. What is the role? There are plenty of questions on pathogenesis, Dhiren. I'm avoiding them because pathogenesis will take us to the breakfast tomorrow morning. There's so much speculation and so much of confusion on pathogenesis. So I'm avoiding pathogenesis questions actually, because there's so much of debate on that. Now, what is the role of tiered investigations? Like the Northwest Hospital in US and the ACR recommendations say that whenever you are dealing with MIS-C, probably do a tiered step 1 tier and step 2 tier. Any take on that, Dinesh or Dhiren?
Sir, there are 2 things. One is, depending where you're working, there are 2 markers which we require. One is inflammation. CRP should be sufficient. Need not to get an IL-6 or any other marker. Second is D-dimer, which Dr. Dinesh has well emphasized that this gives an idea about the vasculitis. And third is troponin I or BNP or whatever is available. So these are the 3 markers which gives you what type of pathogenesis is dominating in this patient. So probably these 3 should be fine.
I think before we close, Dr. Dhiren, Dr. Dinesh, would you agree with me that we are learning a lot on long-term effects of viral illness after COVID?
I think we all are learning a lot about COVID. I think at this stage, we do not know how really it is going to affect the pediatric population. Further, at this stage, we still are learning how to ideally diagnose, how much we should really diagnose, how aggressively we should manage. Like today we discussed how aggressively we should give IVIG, Should we give 2 grams per kg straight away? Should we give it over? The cost implications of it, how much investigations to be done. But I think at this stage, it's very important to prevent mortality. It's very important to diagnose them early. It's very important to initiate immunomodulator therapy early. So my message would be to be aware about the diagnosis, initiate treatment early, because I know we can't afford to lose life. As Dhiren has been saying, that over a period of next 6 months, more data will come up. And I think a lot of data will come up from India, because of seeing the number of cases as I was presented. From Boston, there were 28, the whole 8 hospitals, there 58. And then you can see just from Gangaram and from Rainbow, there have been so many cases already. So, and the Pediatric Critical Care Society has collecting data from all over the country. And we will have such a huge data. And Satish also has a lot of cases. So I think we'll have huge data from across the country. Learn from that. So
Satish, if I don't give you a chance, I'll feel guilty about it. If you can be very short, then we'll go ahead. Satish, unmute your mic. Unmute your mic. Dr. Satish, please unmute yourself.
Yeah, sorry. I miss actually my internet stopped working. Yeah. So I tell you the actual experience about post-COVID problem. In pediatric patients, they recover very quickly. The beauty of that, they are not having any morbidity presently. But in adult, I'm talking about asymptomatic or mildly symptomatic patients. Around 12 patients in past 15 days, I'm talking about close friends and doctors having tachycardia. They work out the tachycardia. They are irritable. They are like chronic fatigue syndrome they are landing in. Though there is a lot of anxiety. Everybody is, just, telling them, okay, it's just anxiety. You don't worry. You take alprazolam and all that. No, they are not. It is not related with anxiety. Now data is saying 78% of the cardiac MRI done on this stable looking patient had abnormality. So I saw this clip on Times of India, and I found it a doctor who got his MRI done in one of the Apollo hospital. I talked to him personally because I was interested. There were 12 patients who were really troubled by this tachycardia. Post-COVID, I'm not talking about lung problem. I'm talking about pure mild symptomatic and even tachycardia and having extensive weakness. And he found that he got his MRI. It is a very difficult protocol, 60-minute protocol. All troponin I, ECG, echo, everything normal, but myocardium having inflammation. Got beta blocker, now really settling. There are 2 patients for 1 month, they are having tachycardia post-COVID, still not settled. Pulmonary fibrosis. Within a week, many of the patients land up in pulmonary fibrosis. We don't know. This virus has read us very beautifully, but we are not able to read him, read her, whatever sex we can use. Say, past 7 months have passed and this has really baffled us.
Satish, anything you want to add, Satish?
Yeah. Just one quick question to both. I won't take a lot of time.
No, not at all. Please go ahead.
Yeah. 35-day-old baby came to us day before yesterday, Dinesh, and child is having ventriculitis with meningoencephalitis, presented with 6 days history of fever and seizures. Now, okay, got the MRI done. It was ventriculitis and meningoencephalitis, but the RT-PCR is strongly positive, and the child landed up onto respiratory care. Now, the big question is the child suffering from meningoencephalitis of maybe, we're still awaiting the culture results of gram-negative, we don't know, or is it from or with COVID positive? What is the status of the CSF PCR? I tried calling my friends in Sydney and the US. Nobody seems to have a clue. How do we go about because it's in the next 1 month, we're going to have more of these. So any idea, Dhiren or Dr. Dinesh? What about
CSF lymphocyte count?
See, it's 90% neutrophils, 90% neutrophils, 186 cells and 600 and odd proteins. So it's with ventriculitis and meningoencephalitis. Yeah. Okay. So, but what to do with the CSF? I have the sample still stored at -80 degrees centigrade. what to do with the sample.
Okay. Dr. Dinesh, you want to answer?
Yeah, I think two things I'll answer and then you can take over, Dhiren. So as far as the babies, I think what we have found, we had a newborn like this who presented with seizures, persistent seizures who came off. We had meningitis and his RT-PCR has come positive, but the CSF was lymphocyte dominant. And for your question about CSF PCR,
This CSF was neutrophil dominant, yeah.
But this CSF was lymphocyte dominant, and we were actually looking for someone who could do anything for the CSF, but there was no way to sort of, no one was at that time, it was in the early phase of COVID. So it was very restricted in Telangana even to do the testing. So there was no way sort of we could confirm that. But coming back to your case, I feel we are having co-infections a lot of time.
Yes.
Whether considering that whether this is a child who already has a gram-negative meningitis, ventriculitis, who also got exposed to RT-PCR with the epidemic and has got an RT-PCR, because the way your whole presentation looks like is he's got a co-infection with
most probably
looks like that. Yeah.
Because his IgG and IgM are negative, but the RT-PCR is positive. So I've spoken to some guys in Sydney. They said they've got a beautiful lab set up. If you can send the CSF sample, maybe it's an ultra-sensitive PCR, I believe. I don't know. Any thoughts, Dhiren?
Sir, when I was giving answers, so I Googled it. So what they did, in a 40-year, they reported from the China that in a 40-year female, they did the RT-PCR, same RT-PCR in CSF of that lady. And she was diabetic and it came positive probably.
Okay.
I couldn't read it. But I mean to say, what you can do, because the government has put in control. Otherwise, we used to send the nasal specimen, and we used to send. I try to do a lot of these things. So means normally it is a standardization.
Yes.
It is a standardization with the nasopharyngeal and throat swab, and with the sputum and the bowel sample. But it's not like that you cannot do.
Yes.
You won't get the report. You won't get the report, they won't release the report. But if it come positive, then it's positive. Yes. If it come negative, it is not been standardized.
Yes, absolutely.
So if you can send by your name, and if it come positive, then you may be in trouble, but patient, you may be able to diagnose the patient. So presently, I mean to say, Google has got every answer and try to find. But I totally agree. I went
reported cases, there are only two. Yeah, Dhiren, total reported cases were only two. There's one from Japan, 24-year-old, a PCR negative, but MR imaging, the CT scan of the brain, that was suggestive of COVID. And the same, there was one in Germany, a newborn baby with meningoencephalitis, just as Dinesh said. All of them were this thing, except the RT-PCR being positive, Dinesh. So
what I could... Yeah, in literature, most of the newborns who have developed these RT-PCR positive, but the disease process was entirely not related with the COVID-19.
Yeah.
So they were like, most of time it is a bystander rather than actual ventriculitis.
Hopefully, let's hope that it's only a bystander.
I think the newborn experience has been...
I think we are overstepping time, sir.
Yeah.
I think we are in depressing times, but let's not end this discussion on depressing note. Because with modern times research, the benchmarks for research have reduced, sir. A lot of benchmarks have cut down. We have started using technology in medicine. We are understanding molecular biology better. And we are looking forward for newer vaccines and newer modes of delivery of vaccines. So let us not end on a desperate note or a depressive note. There are exciting time ahead. And I'm sure Satish, Dinesh, and Dhiren will have a lot of work on hand. Over to Dr. Bhaskar. Thank you so much for giving us an opportunity for this. Dr. Bhaskar.
Thank you so much, sir. Thank you a lot for giving us the opportunity.
Thank you, Dr. Sanjay, for your excellent professional moderation and for handling tough speakers. A special thanks to both the speakers who had really first-hand experience, one from Delhi and one from Hyderabad. Really, you have demystified so many things which were there in our minds. At least at this point of time, things had become very clear. And Dr. Dhiren had given us a lot of confidence that Don't be panicked to treat COVID-19. Use your common sense. That's a fantastic carry-home message. Thank you, Dr. Dhiren Gupta, for accepting our invitation and presenting so well, despite your webinar which you had in the afternoon. Still, you are looking very fresh and interested to answer the questions. Thank you, Dr. Dinesh, for coming at rescue of one of our senior pediatric intensivist colleague. You have presented so well, you have shown the data. So my special thanks to all the participants. They were more than 180, and even to this time there are 103. So it shows the prominence of the speakers, prominence of the participants like Satish Ganta, who is also taking care of COVID-19 patients. So I thank all, and I request our President, Dr. C.N. Reddy, to make concluding remarks. Over to Dr. C.N. Reddy.
Sir, unmute your mic, sir.
Just one thing, are we going to have dinner after this?
Yes,
No,
sir, we can have a dinner at our home
No, sir,
with family and friends.
I thought from laptop some dish will come.
Oh, okay. That like you are doing you are just like in a seaport, no? We are seeing you very beautiful scenery, back of you, and like that we can made some gimmicks of giving some dinners also. Next time we will plan. Thank you very much. It was excellent presentations by both of the speakers. As our moderator told, it was just super. We had a good experience, a learning experience, sir, by 180 pediatricians of Twin Cities. And thank you very much for sharing you. Thank you, Dr. Dhiren Gupta ji. And also I thank Dr. Dinesh Chirla. We have learned so many things about COVID-19 and also MISC. This definitely is going to help our pediatricians, our participants, our members to give a better services to the children. I thank Dr. Sanjay Srirampur for wonderful moderation, professional moderation, and also he made it very lively interactive session. Thank you, Dr. Sanjay, for your excellent moderation. And I thank all the participants who were there, about 180, and thank you one and all. And I also thank Dr. RSV, and I thank my office bearers of IAPTCB, and over to Dr. Sridhar for vote of thanks. Thank you one and all. Namaste.
Thank you so much, sir. Dr. Dhiren and Dr. Dinesh had made us very clear, up to date today, so that we can not fear about the COVID cases to deal, and well moderated by Dr. Sanjay sir. And thank you all the participants. Really, it's amazing to see 180 plus participants to view the webinars, today's webinar. And I expect the same response from all our TCB members. Thank you one and all. Please press the leave button before you leave. Thank you. Good night.
What about fellowship and dinner?
Fellowship and dinner
Next time we will
on a bigger
plan
platform.
digital dinner and digital cocktails we will plan. It will come to you.
Sure, sir. Sir, I will share my write-up with Dr. Sanjay. I've oversimplified that write-up. We can manage not only pediatric but adults very smoothly.
Please do that, sir. Please do that.
Thank you, sir. Thank you very much.
That's true.
Second presentation, sir. You gave a part 1 presentation and part 2 presentation is there.
It's left over.
It is due. Left over. It is due.
Sure, sir. Sure. So
See you, sir. See you.
Thank you, sir.
All common
Thank you,
sense.
sir.
Thank you. Bye-bye.
Thank you, sir.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.
Bye. Thank you.